stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Good afternoon, dear delegate, distinguished guests. Welcome to our session this afternoon about the cardio-oncology. Our panelists this afternoon include me, Dr. Mai Chong Hua, and Dr. Lilian Leong from Hong Kong. Dr. Lilian Leong is founding president and immediate past president Hong Kong College of Radiologists. In this afternoon, we will have 4 reports starting from 4 p.m. to 5:30 p.m. The time for each presentation is about 20 minutes. So it is recommended that each presenter only report no more than 20 minutes to ensure timely. And after finishing all 4 reports, we will move on onto the discussion session, meaning there is no discussion after each report, and all attenders can submit question via the chat box in this Zoom software. Now, without any further ado, we are pleased to present the first presenter with the topic cardiac tumor diagnosis and management. Please warmly welcome to Professor Tam Meng Kuong with his presentation. Yes, please.
Mr. Professor Chairman, ladies and gentlemen, today I would like to present to you my topic on diagnosis and management of cardiac tumor. Thank you for your cooperation. Dear colleagues, today I would like to present to you the topic on diagnosis and management cardiac tumor. The cardiac mass frequently present a significant diagnostic and therapeutic clinical challenge. The lesion that can be either neoplastic or non-neoplastic. Moreover, cardiac tumor may be symptomatic or during evaluation or unrelated problem of physical feeling. Cardiac tumor involving any heart structure. In this topic, we shall to provide to you an overview of cardiac mass, focusing on each cardiac chamber and providing epidemiology, clinical presentation, imaging, histopathology, diagnostic, treatment, and prognosis of cardiac mass. According to the 2050 WHO classification update, myocardial tumor are divided into benign tumor, tumor lesion, malignant tumor, and pericardial tumor. Cardiac tumor are divided into primary and secondary form. Approximately 10% of the cardiac tumor are malignant and 19% benign, in which mostly is mesothelioma. Mesothelioma account for 50% of all benign cardiac tumor in adults, and only a small percentage in children. Rhabdomyoma is more common benign tumor in children. The other benign cardiac tumor include fibromas, lipomas, and the remaining 10 to 20% primary cardiac tumor as malignant and usually as sarcomas. The primary cardiac sarcomas occupy about 1% of the unshorted sarcoma and are somewhat common malignant PCT. Angiosarcoma and unclassified sarcomas account for about 76% of all cardiac sarcoma, of which angiosarcoma is more common. Rhabdomyosarcoma is a more common cardiac sarcoma in children. Some cardiac sarcoma observed as leiomyosarcomas, synovial, osteofibro, neurofibrosarcomas. We talk about the clinical presentation. There are some clinical features that are seen in many cardiac tumors. Symbolization occurs frequently. may be multiple small emboli, mimic the vasculitis or endocarditis, and cerebrovascular event. Right-side tumor embolize to lung, making pleuritic symptoms and right heart failure. The obstruction. Atrial tumor may result in obstruction of atrioventricular vein flow and may mimic venous stenosis. Ventricular tumor may obstruct the airflow, leading to chest pain, syncope. Arrhythmia, intramyocardial and intracavity tumor may affect cardiac rhythm due to direct infiltration of the conduction tissue or irritation of the myocardium. Atrioventricular block and ventricular tachycardia are frequently and may be with sudden death. And now we talk about the measurement. Atrial measurement is most common cardiac tumor, comprising 50% of tumor, occurring more commonly in women and usually diagnosed between 50 and 70 years old. 90% is left atrium and 19% is celerity. The clinical feature may mimic infective endocarditis and vasculitis or other inflammatory disorder. The differentiation from intra-atrial thrombosis is important. Surgical resection is available as soon as possible after diagnosis, as the rate of embolization is high. We recommend that recurrence is possible and long-term echocardiographic follow-up is necessary. This slide is showing the microscopic specimen of atrial measurement. You can see the specimen is irregular, shiny, and colored. This slide is showing the left atrial measurement prolapsing across and obstructing the mitral valve on echocardiography. You can see now the left atrial measurement prolapsing across and obstructing the mitral valve on echocardiography. As a benign tumor of the heart include rhabdomyome, lipoma, fibroma, and angioma. Rhabdomyome is the most common cardiac tumor in children. Lipoma are usually asymptomatic. Lipomatous hypertrophy in the intercardial septum should not be mistaken for intracardiac tumor. Papillary fibroelastomas have a high incidence of embolization. You can see this echo image of an optic papillary fibroelastoma. And now you can see the giant lipomasarcoma in left atrium on TEE. B. On CT scan. C. The differentiated liposarcoma with osteogenic area. D. TEE long Asci view. E. Image after surgical excision. And now we talk about the malignant primary cardiac tumor. The majority are the sarcomas, Asci angiosarcomas, rhabdomyosarcomas, most malignant primary cardiac tumor located in right atrium. The incidence of primary intracardiac lymphoma is increasing now, and treatment is rarely curative. And now you can see the cardiac angiosarcoma is lung metastasis. A. On echography. B. On cardiac CT. C. On CMR. D. Area of intense metabolic activity on the PET CT. You can see the metastatic pleomorphic sarcomas with a neoplastic mass, extensively necrotic area, destroying the subtotality of the left atrium. You can see the metastatic pleomorphic sarcomas is a pleomorphic and anaplastic shown. The secondary cardiac tumor. Secondary cardiac tumor are usually epicardial and asymptomatic. The metastasis is rarely limited to the heart, and pericardial effusion is common. Melanoma, leukemia, and lymphoma are more commonly associated with metastasis to the heart. This slide showing how to diagnose and treat a patient when a heart tumor is suspected on physical examination. The first patient undergo thoracic echocardiography. If in doubt, genioesophageal echo, tri-echo, or cardiac MRI, PET-CT, or chest and abdominal CT if metastases are suspected. If marks is diagnosed, a biopsy or surgery must be done. And now we talk about the treatment prognosis. Complete resection is treatment of choice for sarcomas, but patients develop a recurrent disease and die even if the tumor can be completely resected. The largest surgical trial consisted of 34 patients treated at the Mayo Clinic over a period of 32 years. The median survival was significantly longer, and a complete resection was possible. As general rule, resection should be attempted if feasible, provided the patient has a stable performance status and no or limited metastatic disease. The benefit of adjuvant chemotherapy and radiation is unknown. The overall survival of the patient with a malignant cardiac tumor remains poor. The patient with cardiac angiosarcoma have a least favorable outcome. The systemic therapy for cardiac angiosarcoma have been particularly disappointing up to now. The conclusion. In the field of the cardiac masses, the differential diagnosis is important. Imaging CMR, PET, CT may increase the sensitivity and specificity. The definite diagnosis require histologic examination in challenging scenario. Histopathology remains the gold standard in diagnosis. Advance in understanding of molecular mechanism have resulted in novel medical therapy that obviate the need for surgery. In the era of the next generation sequencing and precision medicine, our understanding of the lesion will undoubtedly improve. Thank you for your attention.
Yes. Thank you very much for the nice presentation, Dr. Tam Minh Cường from Hanoi, Vietnam. From his report, we know that the two cardiac tumors in Vietnam, especially in Hanoi, I think it's very. Sometimes we have to meet this disease. From his report, we know that almost cardiac tumor is benign tumor. It's about 20%. For example, lipomas, fibroma, and so on. And we have about 10% of malignant tumor, for example, sarcomas, angiosarcomas, and neuroplasm, and so on. Yeah. Now we have many methods for the diagnosis. For example, we can use this, ultrasound, CT, and so on, and especially we can use the PET-CT. And now histopathology is now gold standard in diagnosis and treatment. So we have many tools for the treatment. So now we would like to invite Dr. Lilian to continue, please. Yeah.
Yes, it's my pleasure to introduce our next speaker, Dr. Carmen Chen. Dr. Carmen Chen is now the consultant cardiologist and a clinical honor associate professor at the Department of Medicine, Queen Mary Hospital, University of Hong Kong. She specialized in advanced non-invasive cardiac imaging, and she's active in research, guideline, and reviewer in several peer group reviewed journals and author of book chapters. Currently, she's a council member of Hong Kong College of Cardiologists, convener of CMR chapter and Women's Heart Health Campaign. She's a founding member and international license officer of Asci and the program chair of the Asci 2022 to be held in Hong Kong. Thank you. So Dr. Carmen Chen, and her topic today is the role of echocardiography. Dr. Chen, please.
Good afternoon, ladies and gentlemen. I would like to present the role of echocardiography as a team player in cardio-oncology. Cardiovascular disease and cancer are two leading causes of death worldwide. While in my hometown, Hong Kong, we are no exception. So if you scan the QR code at the right lower corner, you can see that cardiovascular disease and cancer are also the top two leading causes of death here. With the improvement of the cancer therapy, survival rates from cancer are improving. And the improved survivalship coupled with increased recognitions of an expanding range of adverse cardiovascular effects on many established and novel cancer therapies. Though the two diseases, cancer and cardiovascular disease, are quite different entities, however, the path of the patients is quite similar. The patients are being predisposed to some risk factors and then they develop the disease. And among the survivors who have received some sort of a previous treatment had some long-term sequelae. So as in cancer, the patient may undergo the chemotherapy or radiotherapy, and in long run, they may develop a cardiovascular disease. And it is vice versa for the patient who have the cardiovascular disease being treated with the medication or intervention. So this is a blue-eye diagram showing a very dramatic and unprecedented increase in the clinical cancer immunotherapy combination studies. And the extent actually involved many different parts of the body and many different organs. And many of them have been documented to have some sort of LV dysfunction as a result of the different types of immunotherapy. So the Cardiology and Oncology Professional Society has put on some statements on the implications of these cancer therapeutics on the LV dysfunction, on the clinical use, and also the cardiotoxicity recognized, and also on the LV monitoring in oncology practice. Among the anthracycline, the HERP2 therapy, the VEP inhibitor, or the proteasome inhibitors, and also the immune checkpoint inhibitor. And among them, those patients who have a stage C symptomatic heart failure, there are clinical data and guideline recommendations on all these types of cancer therapeutics. However, for the earlier recognition, including the risk stratification and modification, and also the screening stage, the stage B for LV dysfunctions, currently, they just only have a clinical data and recommendation for the first 3 cancer therapeutics as shown here. Earlier this year, the British Society of Echocardiography and also the British Cardio-Oncology Society has published a guideline for the transthoracic echo assessment of patients having cancer, adult age, receiving the anthracycline and or the trastuzumab. So the patient will have a baseline assessment whether they are at high risk of having a cardiotoxicity, and then they will undergo a baseline echo assessment, which should include the 2D LVEF, 3D LVEF, global longitudinal strain, and RV assessment. And for those who are abnormal, should refer to the cardio-oncology team earlier for some tailor-made, individualized assessment and treatment. And for those who have not, then they should have at least 3 months interval assessment of echo by echo during their treatment process. And for those patients who may fall into one of the following 3 categories, should also refer for the cardio-oncology for earlier assessment, namely the cardiotoxicity defined by a decrease in ejection fraction of absolute 10%, with the ejection fraction less than or equals to 50% now, and the regarded as a cardiotoxicity, or the possible subclinical cardiotoxicity, namely the LV ejection fraction of less than 10% compared with the prior one, with the current LVEF still more than or equals to 50%, and the global longitudinal strain increased by 15%. And also the last group, possible subclinical cardiotoxicity, which is either they have a ejection fraction of drop by 10%, with the current ejection fraction less than or equals to 50, or there will be an increase by 50% of the global longitudinal strain. And for those patients who have not have these sorts of fall into either of these 3 stage, they should at least have another echocardiogram assessment at about 3 to 9 months after the completion of their treatment. So very briefly mentioned on the minimal requirement of the echo parameter. Well, it is an example of the apical 3D echo, which is used for the 3D volume and also the ejection fraction measurements. Some explanatory notes also be available when you try to look up at the full versions of their guideline. and also have the apical 4-chamber, apical 2-chamber 2D, measuring using the Simpson's biplane to measure the volume and also the ejection fractions. And also the apical 3-chamber 2-chamber to assess the global longitudinal measurements. And the T2 Doppler should also be included, and similar modified apical 4-chamber should also be used for assessment at the right heart. And the continuous wave Doppler is recommended to be included for the tricuspid valve, and also the apical 4-chamber wheel at the right heart to measure the DTI as well. So who are those patients who are at high risk of cardiotoxicity? Well, we can divide it into two groups. That is, the one is the therapy-related risk factors, and the other is the patients-related risk factors. So for those patients who have increased lifetime dose of anthracycline, including the more than 250 milligram per meter square of doxorubicin, is regarded as high risk. And for those who have a greater than 400 milligram per meter square, will be regarded as very high risk. And those patients who have a prior anthracycline or the trastuzumab related cardiotoxicity, or they need to have a sequential repeated dosage of these two chemotherapeutic therapy, patients are also regarded as a high risk. And those patients who receive high dose radiation therapy to the central chest, including the heart in a radiation field of more than or equals to 30 grays, are also regarded as high risk. So for the patient factor, so women, middle age or beyond, and they have a previous history of coronary artery disease or some risk factors for the ischemic heart disease, are also regarded as high risk. And similarly, those patients who have impaired renal function, or they have the increase in the biomarkers like the elevated troponin or the NT-proBNP, suggesting the presence of the heart failure, are also regarded as a high risk. Well, this is a slide showing that there is actually no consensus on how frequent the echocardiogram should be performed to our patient group. But at least it should be a kind of a serial assessment, as especially for those high-risk patients. And the frequency would depend on the service ability to the healthcare providers' capacity, and also on the availability of the expertise. However, cardio-oncology is not just a disease of heart failure. Actually, it involves many other parts of our cardiovascular systems, including our peripheral arterial disease, or it can affect the atrial fibrillations, and also the healthiness of the and also on the healthiness of our pulmonary vasculature. And so what we mentioned here is just part of it. Well, nowadays we are actually more proactive, not just identify the disease when they have been developed, but we are targeting at earlier stage, including risk stratifications and early detection of injury, and see how we can predict the recovery as well. So that is the true beauty of the involvement of the different imaging modality, including echo, the nuclear PET, cardiac, CT, and MR, to have a complementary role in making all these things from happening. And it is an example on how CMR can be used to detect the different features of the cardiovascular sequelae related to the cancer treatment. It is particularly useful in detecting the pericardial involvement, the myocardial involvement, like whether it's any myocarditis, and also what is the blood flow at the myocardial level. We can also take a look at the endocardial involvement, like those who have some sort of damage of the valvular functions due to the prior radiotherapy treatment. It can also help to assess the blood flow through the aorta. And so there is a lot of things we can get from doing the MRI exam. So the following time, I would like to share with you two examples to illustrate how the different imaging modality and play their role in the management of the patients. So the first case is a 43-year-old woman with a history of CA breast presented with few weeks of bilateral ankle swelling and ascites. She was diagnosed almost 10 years ago, received the left-sided lumpectomy and followed by radiation therapy. She has no prior history or risk factors for ischemic heart disease and no family history of ischemic heart disease of stroke. And this is the ECG after admission. So from the ECG, basically there is only some non-specific T-wave inversions over the precordial leads. And here is the echo exam of the patient. Well, you can see that there is a long tubular left ventricle. It is a relatively small in size and also a bilateral enlargement of atrium. And if we take a look at the pulse Doppler pattern at the mitral inflow, you can see the ECG tracing, which is illustrated by the yellow tracing here, by the green tracing here. And the other tracing here is actually the records from the respirometry. And you can appreciate that the tissue Doppler pattern actually varies with the respirations. And in fact, there is a drop in the peak transmitral inflow with the inspirations, as defined by more than 25% drop in the peak level. And when comparing the pulse Doppler and also the DTI of the septal wall and also the lateral wall at the mitral valve annulus level, actually the E pi at the lateral wall is reversed when compared with the normal value, so suggesting the presence of constriction here. And since the echo is only sensitive to pick up about one third of the patients with constrictive pericarditis, CT and also the MR has the role. So you can see that from the CT fluoresce, there is a thickened pericardium. And if you take a look at the free breathing MRI cine image, you can see that there is a flattening of the ventricular septums with the inspirations. That is when the diaphragm is more fat, and there is also a early diastolic filling that can be very nicely demonstrated here. So the patient was diagnosed to have constrictive pericarditis. Unfortunately, the symptoms only improved with partially with the diuretics, and eventually the patient undergone the pericardectomy, and the recovery is very good. So the second case is a 50-year-old woman with insidious onset of bilateral lower limb swelling for a few months, associated with shortness of breath and exertions, and also the PND, occasional palpitation. For the past medical history, she has hypertension and also GERD, and the only medication is on right now is the Norvasc, which is a kind of calcium channel blocker, 5 milligram daily. And it is the ECG after admission. I think the most alarming thing is a very low voltage at the limb leads. So what is the diagnosis for this patient? So let's take a look at the echo. Well, basically, I'm pretty sure that you can appreciate that there is the thickening of the LV wall at the parasternal non-wheel and also the short axis wheel. It is a very kind of circumferential thickening. And similarly, you can see that at the 4-chamber wheel, the LV mass is also increased, and there is a very thin rim of pericardial effusions at the subcostal view. And here I showed you the tissue Doppler and also the speckle tracking pattern of the patients. Well, you can see that at the tissue Doppler, there is a decrease in the E-pine at the lateral wall. And when we try to look at for the speckle tracking, which is a kind of measurement of the different velocity and also the functions of the myocardium, there is actually a decrease in the peak, apart from the overall, apart from apical sparing of the myocardial function. So with the evidence of increased diastolic heart failure, diastolic functions, and also the apical sparing, well, it is a classical findings in those patients with cardiac amyloidosis. So the patient underwent a delayed hyperenhancement imaging MRI study. You can appreciate that there is a diffuse pickup of a contrast at the whole myocardium, all along the area with the hypertrophic myocardium, and also a very thin rim of pericardial as well. And on the CMR, the T1 mapping is more than 1,300, which is grossly elevated, also supporting the working diagnosis of cardiac amyloidosis. So those patients who have echo or MRI evidence suggestive of cardiac amyloidosis, we usually would suggest the clinicians to review the signs and symptoms of these patients, and also the laboratory result like the NT-proBNP, the EGFR, the troponin, and also check for the serum protein electrophoresis and also the serum immunofixations and the urine for the free night chain. And if there is the evidence of the presence of the plasma cell dysplasia, then proceed for the bone marrow biopsy to confirm whether the patient have the light chain amyloidosis. Otherwise, consider the titanium-99M phosphate scanning. If it is negative, then the chance of cardiac amyloidosis is very unlikely. However, if it is positive, then we need to check for the TTR mutation to see whether it belongs to the hereditary cause of the ATTRM, or it is actually from the non-hereditary, which will involve different types of treatments for the patients. And this is the example of what the patient got. You can see that there is an increase in the uptake at the hearts, suggesting that that this is the presence of the cardiac amyloidosis, the ATTR. So in conclusion, with the advancement in treatment, cardio-oncology is a rapidly growing field. And new cardiovascular challenges from those cancer patients are expected. Echocardiography is easily accessible, and it is good for the initial assessment. However, multimodality imaging also plays a very important role throughout the journey of our cancer patients. So thank you for your attention. And here I showed you two buildings in Hong Kong, which is taken from one of uprising, very young photographer. And here it is what we get when everything is clear up. So we will hold the Asci 2022 next year in Hong Kong, and I hope to see you all there real soon. Thank you for your attention.
Yeah, thank you, Dr. Carmen, and thank you for your excellent lecture demonstrating effect and management of pharmacological treatment for patients undergoing cancer therapy, and all these very important protocols that you show us. And I really like the excellent images and video. And unfortunately, Dr. Carmen Chan cannot join us for the discussion because of other clinical commitment. So now can I introduce our next speaker. And our next speaker is Dr. Yong Jin Hong. And Dr. Yong Jin Hong She is from the, Korea, and currently is a associate professor in the Department of Radiology, Severance Hospital, Yonsei University Health System in South Korea. And she has been associated with many professional society in radiology and cardiology and cardiovascular imaging. And she did a lot of research and work on that. And her topic today is CMR and state of the art. And Dr. Yongjin Hon, so please.
My name is Eugene Hong from Yonsei University in South Korea. Today, I'm going to present cardiac MRI in cardio-oncology field. I'm gonna start with 3 interesting cases to you. This patient is 68-year-old male whose LGE image shows a thrombosis with dark signal intensity in aorta. The subendocardial delayed enhancement due to infarction in the inferior lateral wall was noted. In his medical record, he was diagnosed with malignant mesothelioma 1 year ago. He was admitted to the emergency room with chest pain, which was started 1 hour ago. The patient was diagnosed with STEMI and total occlusion of distal PD branch that was identified angiography. Since he had undergone cisplatin chemotherapy 1 week ago, I think the chemotherapy might have caused arterial thrombus and myocardial infarction. So this first case is on aorta. We know many anti-cancer agents are known to cause thromboembolism. Cisplatin, one of the alkylating agents, is the most well-known drug, while other drugs include angiogenesis inhibitors, VEGF inhibitors, and newly emerging small molecule tyrosine kinase inhibitors are known to cause thromboembolism. Let me present the second case. The 57-year-old woman who complained about dyspnea had taken her X-ray. The X-ray indicated an enlargement heart as well as pleural effusion. And this enlargement have occurred over the course of a month. When cardiac MRI was performed, the result revealed that elevated LVEDV of 135 milliliter per PSA and a reduced LVEF of 14%, which is suggestive of the CMP. Increased native T1 and ECV at 1300 milliseconds and 50% respectively, but there was no focal LGE in LV myocardium. According to her past medical history, she had been diagnosed with stage 4 lung adenocarcinoma in 2015, and she received target therapy for an EGFR mutation, after which she had been stable for 3 years. Starting in 2017, she participated in a clinical trial on a third-generation EGFR TKI drug. Based on her medical history, there was no explanation for the heart failure other than the EGFR TKI drug. So the diagnosis was a cancer therapy-related heart failure. So the treatment was discontinued. At 1 month follow-up after discontinuation of the drug, the cardiomegaly demonstrated a small improvement. Currently, the patient is being treated using a different drug. One of the main side effects of chemotherapy is heart failure. Heart failure is most commonly attributed to chemotherapy agent in the anthracycline family. It's also been widely reported as the cause by the newly emerging tyrosine kinase inhibitors. As patient is showing improvement following the discontinuation of the drug, it is essential to find an early diagnosis. The last case is about a 76-year-old woman who was diagnosed with multiple myeloma. She visited the hospital with complaint of dyspnea and received cardiac MRI. MRI shows the LVEDB was elevated to 122 per BSA with reduced LV systolic function of 34%, which is suggestive of DCMP. The LG image demonstrated a multifocal subepicardial pattern, which is suggestive of myocarditis based on the elevated T1, ECV, and T2 values. This patient had previously received a 19-cycle carfilzomib treatment 5 months ago, and we suspected that this case involved myocarditis caused by carfilzomib cardiotoxicity. Unfortunately, the patient's heart failure did not improve and the patient died 6 months later. Carfilzomib is a second-generation proteasome inhibitor that is approved for patients with relapsed or refractory multiple myeloma. However, there are many reports about cardiotoxicity associated with carfilzomib. It is known that proteasome inhibition has the potential of significant cardiotoxicity via the accumulation of intracellular protein aggregates. The cumulative incidence of cardiotoxicity is about 8%. The field of cardio-oncology, with its focus on cancer therapy-related cardiac dysfunction, has been gaining attraction. Cardio-oncology is a new field of interest that focuses on detection, monitoring, and treatment of cardiovascular disease occurring as a side effect of chemotherapy and radiotherapy. While the survival rate of cancer therapy has increased due to advances in technology, CT-LCD often determines the survival rate of cancer patients. Regarding cancer therapies, many cancer therapies cause heart problems. These therapies include chemotherapy, molecular target agent therapy, and mediastinal irradiation. They cause LV dysfunction, hypertension, and other conditions such as arrhythmias, coronary artery diseases, and thrombus formation as well. Heart failure caused by cancer therapies has a worse prognosis than idiopathic cardiomyopathy. These drugs are somewhat of a double-edged sword in that they can help to treat cancer, but they can also cause fatal side effects, leading to the death of the patient. In cases in which fatal side effects occur, cancer treatment may inevitably have to be discontinued. As such, patients must be closely monitored for side effects throughout cancer treatment to enable the early detection and side effects. The field of cardiac MRI plays a big role in the monitoring and early detection of cancer treatment-related cardiac problems. The MRI is a promising tool in cardio-oncology field. Many guidelines emphasizing the importance of cardiac MRI are being published in the field of cardio-oncology. Nevertheless, despite its accuracy, some of the disadvantages of MRI include the low utility, long scan times, and discomfort among patients due to need to hold their breath for a long time. The ESC guidelines recommends the use of cardiac MRI as baseline evaluation in situations where TT images are suboptimal. The ASCO guidelines recommends the use of cardiac MRI as the monitoring tool during or after cancer therapy in cases in which a TTE is unavailable or not technically feasible. Nevertheless, with the rapid advancement in technology, MRI is gradually developing as a tool that can obtain quality images in a short scan time. You can obtain the images in seconds. For example, cine images, which were used for observing LV function and typically took around 6 minutes to process. Now, cine images can be processed in just 10 seconds using compressed sensing and real-time method without sacrificing on image quality. Heart-freeze LG method allows to obtain quality images while patient breathes throughout the scanning process. Furthermore, in addition to examining focal fibrosis using the LG method, you can now obtain T1, T2, and ECB maps, enabling tissue characterization in the myocardium. The current diagnosis of CT-LCD is defined based on LV systolic function in accordance to echo or MOGA result. Typically, the most widely used criteria for CT-LCD include a reduction of 5 to 10% of baseline LVEF value or absolute to LVEF value less than 55% or 53%, which is the standard value from 3D echocardiography. So I will tell you about LVEF measurement using cardiac MRI. Cardiac MRI offers highly accurate EF measurement and is known as the standard of reference for ventricular volume and functional measurement. Previously, there was a study on the inter-study reproducibility of cardiac MRI and echocardiography parameters. As you can see, the variability of EF following two repeated measurements of echo and cardiac MRI had a lower variability than echo in all patient groups. Even in the average variability across all patients, the variability of MRI was 3.7% and echocardiographic variability was 11.5%, which was nearly threefold. Among the MR parameters, in particular LVEF and LV mass, which was important parameters in cardiotoxicity, demonstrated lower variability. Recently, there is a study on the variability of CMR in CT-LCD patients. A total of 30 normal subjects and 15 chemotherapy patients diagnosed with CT-LCD and 15 patients without CT-LCD were included. Each group was taken MRI baseline 3 months and 6 months after chemotherapy. Temporal change and variability in LVEF, GLS, in CMR or echocardiography were compared. In 3 groups, minimal overlap was observed in 3D echo EF, echo GLS, and CMR EF in temporal variability. These parameters also demonstrated low inter-observer, and inter-observer test-retest variability, which is suggestive of their utility in diagnosing CT-LCD. In addition to above, I will talk about MRI applications other than LVEF in cardio-oncology. One of the things to keep in mind here is that the mechanism of cardiotoxicity by chemotherapy is microstructural injury due to O2 free radicals. It's not a functional disease. The main strength of CMR is tissue characterization. T1, T2, and ECV will be helpful in diagnosis of cardiotoxicity. I would like to talk about some animal experiment in cardiotoxicity. Previous research have demonstrated that structural injury precedes functional change. We have generated cardiotoxicity rabbit model by injecting doxorubicin. The rabbit subjects were serially followed by T1 mapping MRI from baseline to 16-week treating period. The result shows that T1 mapping parameters serially increased during the treating period. Native T1 significantly increased from 6 weeks of treating period. ECV significantly increased from 3 weeks of treating period. Interestingly, ECV significantly increased earlier than LV dysfunction. Another study was conducted to examine the histopathological findings reflected in change in native T1, T2, and ECV. The histopathological findings and MRI parameters of 36 cardiotoxicity rats were compared by 2 weeks. The 4 main histopathological findings for doxorubicin-induced cardiotoxicity were myocardial injury, interstitial fibrosis, inflammation, and interstitial edema. These 4 histopathological findings were quantitatively scored. It was found to be particularly worse in subjects treated for a longer period for myocardial injury and interstitial fibrosis, but findings varied in subjects with interstitial edema or inflammations. Upon the examination of the correlation between histopathological findings and MRI parameters, the histopathological finding that demonstrated the great correlation with native T1 was myocyte injury, and the histopathological finding that demonstrated the great correlation with ECV was fibrosis. Our findings demonstrated that quantitative MRI parameters are useful in observing subclinical myocardial change in cardiotoxicity rat models, and that native T1 and ECV are good indicators of myocardial injury and fibrosis respectively. In conclusion, cardiac MRI is a useful modality in cardio-oncology field. The main strength of CMR is tissue characterization. It may be useful in early detection of cardiotoxicity quantitatively. Additional researches will be carried out to determine how to best integrate CMR measures into guidelines. Thank you for your attention.
Thank you, Dr. Horn, for giving us such a comprehensive talk and raising the awareness and importance of using CMR to look at the cardiovascular toxicity caused by many cancer therapies and the early detection of damage, both functionally and histopathologically. This is really useful for our better management of our cardiac patients. And for our next speaker, I have the pleasure to introduce Dr. Choi. Dr. Yun Choi, he is a professor in internal medicine in the Gangnam Severance Hospital of Yonsei University College of Medicine, where he obtained his training and his master and PhD degree of medical science. And his academic appointment is now, he's now the professor, but he has been trained in Johns Hopkins School of Medicine and also in his alma mater, Yonsei University College of Medicine in Seoul, Korea. So Dr. Choi will be talking to us on clinical cases or challenges of some cardiovascular effect from cancer therapy. So Dr. Choi, thank you. Please.
Thank you for kind introduction and invitation to this valuable Congress. I'm going to share 3 challenging cases. A 62-year-old woman who had a history of pancreatic cancer surgery 1 year ago visited the cardiology clinic due to incidentally detected right atrial mass during evaluation for pancreatic cancer recurrence. She underwent pancreatic cancer surgery 1 year ago, but there was no mass or uptakes in right atrium at the time. There was no mass on right atrium 1 year ago at the time before pancreatic cancer surgery. Extrinsic compression to right atrium was noted. At that time, pancreatic mass was seen beside the right atrium and the inferior vena cava. No mass was seen inside the right atrium. Operation report showed complete resection of primary cancer without remnant tumor margin. But 1 year later, newly developed masses was clearly seen in right atrium, like this, but there was no pericardial effusion. There are multiple echogenic masses extended from superior vena cava to right atrium. These images are 3D TE of mass. Fixed right atrial mass was clearly seen on CNMRI without extension to adjust the structures, such as right ventricle or pulmonary artery. There was no extension to pulmonary artery or right ventricle in long-axis view. Isosignal intensity was noted in T1 weighted imaging. But in native T1 map, T1 was slightly increased as 1311 millisecond. T2 value was significantly increased as 89 millisecond. LGE imaging shows peripheral enhancement but non-enhancement in the center. In perfusion imaging, partial perfusion was seen like this. So when we review the imaging parameters in this patient, it has high possibility of metastatic malignancy rather than thrombus. When you see this table, metastasis has potentially higher T2 and contrast enhancement compared to thrombus like this. But still, differentiation between benign and malignancy by tissue characterization is not easy. So we performed FDG PET-CT to clearly define malignancy and presence of other metastasis or recurrence. We can clearly see hot uptake in right atrial mass, so we confirm that this is malignancy, highly possible to metastasis or previous cancer. So she finally underwent mass resection surgery, and final pathology was metastatic adenocarcinoma, same with the previous pancreatic cancer. This is another case with left atrial mass. Mass was located in posterior wall of left atrium. Suspicious first impression would be thrombus. But when we see the left atrial appendage in transesophageal echocardiography, which is a usual site of left atrial thrombus formation, but there was no thrombus at all. So we could not clearly make a final diagnosis as left atrial thrombus. Because 1 year ago, he was diagnosed as esophageal cancer. Biopsy finding was squamous cell type carcinoma. At that time, diffuse esophageal wall thickening was noted and biopsy result was squamous cell carcinoma. Para-aortic lymph node was enlarged on chest CT scans. Mild uptake in esophageal wall was seen, but no uptake in left atrium 1 year ago in PET-CT. Of course, at the time there was no mass in left atrium in echocardiography as well. So in this patient, surgical para-aortic lymph node dissection was done to confirm the metastasis. Pathology finding also shows metastatic squamous cell cancer with lymph node involvement. So under the diagnosis of superficial esophageal cancer with left para-aortic lymph node metastasis, radiation therapy and chemotherapy was done. So would it be metastasis to left atrium because it is located in unusual site of thrombosis? However, in PET-CT scans, there was no hot uptake in left atrium, suggesting less possibility of cancer metastasis in this time. After all, we found that he did not take anticoagulation effectively, so after 6-week intensive anticoagulation therapy, the mass was clearly disappeared, which suggests thrombus located in unusual site of left atrium. This is the last case. In a 51-year-old man, multiple lymph node enlargement was detected during hepatitis evaluation. The potential impression was lymphoma, and pathologic diagnosis was diffuse large B-cell lymphoma. Before chemotherapy, baseline echo was done, and left ventricular systolic and diastolic function was normal without any pericardial effusion. So he was treated by R-CHOP chemotherapy regimen. After initial chemotherapy, left ventricular function was preserved and only minimal pericardial effusion was noted after chemotherapy. But 6 months later, he visited our clinic due to dyspnea. Chest X-ray shows cardiomegaly with bilateral pleural effusion. During chemotherapy and follow-up, amount of pericardial effusion was continuously increased, but left ventricular function was relatively well preserved without evidence of chemotherapy-induced cardiomyopathy. What do you think about the cause of pericardial effusion in this case? Follow-up CT showed decreased size but still enlarged several lymph nodes in this case. So is it possible to cancer involvement of pericardium? So to confirm the cause of pericardial effusion and cytology, we performed pericardiocentesis. Unexpectedly, pinkish white fluid was drained, and the level of triglyceride was significantly elevated. So the final diagnosis was chylopericardium without cancer involvement. This is the picture of lymphatic drainage of pericardium. Previous reports showed that retrograde filling of the pericardial lymphatics from the tracheobronchial and anterior mediastinal nodes may play a role in the development of chylopericardium. So I would like to conclude that there are numerous cardiovascular situations during cancer treatment. Accurate understanding of patient condition is important. Selection of best optimal imaging modality can guide accurate diagnosis and efficient treatment. Understanding each modality's advantage and weakness is crucial to select best modality. Thank you for your attention.
Thank you, Dr. Choi, and thank you for sharing with us the excellent cases of cardiovascular situation for the patients under cancer treatment, and the very impressive images and videos demonstrating the importance of multimodality approaches in managing such patients. Thank you again, Dr. Choi. Yeah, we are now up to the next stage of our session. Yeah, and Dr. Cole, Professor Cole. So we are looking at some discussion. Are there any questions? Professor Shaw? Yeah.
Maybe the speakerphone is muted.
I'm sorry. Yeah, I'm sorry.
It's okay, yeah. Yeah.
No, thank you very much for all the participant report. We have finished for presentation. Now we move to the discussion session. Yes. First, I have one question for Dr. Choi. I'm very interested in your nice presentation. How do you think about the values of PET-CT? The PET-CT is diagnosis and management of cancer patient with cardiac vascular disease in your hospital? Yeah, PET-CT, the values of PET-CT. Yeah.
Yes, yes. Usually, PET-CT is routinely followed to early detection of cancer recurrence. Usually, regardless of any cancer, 1 year PET-CT follow-up is generally routine practice in our institution. But in the special case, in the case of active inflammation or differentiation of benign or malignant tumor, we also perform the PET-CT scan. But the limitation of PET-CT scan is the spatial resolution is not better than echocardiography or other modalities. So you have to combine PET-CT and echo or CMI to see the accurate differentiation of cancer metastasis or other disease entities. Thank you for a very good question.
Thank you. Yeah.
MR in the cardiac cases. Do you think that with finding of histopathological affection, do you think the oncologist, it will affect the oncologist direction of cancer treatment to the patients? You understand my question, Dr. Hon? Yeah, if you find there is some histopathological effect on the patient, do you think that will affect the cancer treatment of that patient? As the oncologist will change the cancer therapy or change the drug, whatever, if such finding is positive.
If the ejection fraction is preserved, but ECV is increased, in the case, do you recommend to stop cancer chemotherapy or not? In the case,
that's a good question. Yeah. In our animal study and clinical studies, we found that after chemotherapy, the tissue change occur. Most of cases, tissue change occur. However, in their long-term follow-up, their change decreasing. Yeah, after 1 year or 2 years. So few cases have cardiac event in their long-term follow-up period. So of course, in some cases, there is a severe complication of chemotherapy or target agent therapy. However, in most cases, although there are some tissue change occur, there is no severe problem in their heart, I think. So, and as I show you in my slide, there is no guideline regarding tissue changes of heart. So, more experience and studies have to be done for the reference, I think.
Yes, I'm sure that this is an important area for the monitor and development, Dr. Hon.
I have one question to Professor Hong. Usually, imaging guideline imaging assessment of cardiotoxicity should be every 3 months or every 6 months, because CMR has that kind of limitation for repetitively, and the measurement regarding the measurement of ejection fraction, do you use the STANG method or feature tracking analysis based ejection fraction? Because feature tracking based ejection fraction and strain is very feasible and very easy to perform. So what kind of method do you use? And then how about the repeatability of the CMR during the chemotherapy?
There are many studies regarding strain value in early detection of cardiotoxicity, especially using echocardiography. And there are some studies using feature tracking CMR method for detection of cardiotoxicity. However, we not use strain analysis in our routine practice. And I used some feature tracking analysis for another study. However, I was not sure the accuracy of strain value. There are large interobserver variability in strain measurements. So I'm not sure yet whether it should be done routinely or not.
Any question? No? Yes, continue.
Okay. Yeah. So in my personal opinion, the Morgan scan is not good for the following the ejection fraction or to detect the cardiac toxicity, because the measurement variability of Morgan scan regarding ejection fraction is very high. So echo or MRI, then feature tracking analysis is quite a reasonable method to track the cardiac toxicity.
Yeah, I agree with your opinion.
Okay.
If you have no question, we can stop here. Okay. Yeah. Thank you all of you, because in this afternoon we have for presentation, but we have two presenter have big duty, a very important duty, so not come to here to have a discussion session. Finally, we and I and Dr. Lee Young would like to give deep thanks for all participants, and we hope in the future we will have two occasions to meet face to face, not by internet, by online. Yes, we would like to invite all of you to come to visit Hanoi and Ho Chi Minh City if we winners COVID-19. Yeah, thank you.
Yeah, thank you.
Thank you.
We finish here. Thank you. Yeah.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.